The COX-1 to COX-2 inhibitory ratio determines the relative GI toxicity of a specific NSAID. Standing with chronic PUD, a life-threatening complication usually manifests with upper GI bleeding, perforation and obstruction that are causally associated with H. pylori invasion and NSAIDs usage. At any of the instances, down the line, bleeding is the key manifestation that can be seen with the erosion of an ulcer into an artery. It may be occult and insidious or may present as melena, black-colored stools, or hematemesis, vomiting of blood. Ulcer-related perforation into the peritoneal cavity is generally considered a surgical emergency. Most patients experience ulcer symptoms prior to perforation. Penetration could be another risky event, where the ulcer burrows into an adjacent structure, pancreas, biliary tract, or liver, rather than opening freely into a cavity. Gastric outlet obstruction is related to mechanical obstruction caused by scarring, muscular spasm, or edema of the duodenal bulb, usually resulting from chronic ulceration. With an overall aspect, peptic ulcer disease clinically manifested as abdominal pain that is often epigastric. A typical nocturnal pain that awakens the patient from sleep, especially between 12 a.m. and 3 a.m. Heartburn, belching, and bloating often accompany the pain. Nausea, vomiting, and anorexia are more common for patients with gastric ulcer than with duodenal ulcer. Possible laboratory investigations for PUD are fiberoptic upper endoscopy, also known as esophagogastroduodenoscopy, detects more than 90% of peptic ulcers and permits direct inspection, biopsy, visualization of superficial erosions, and sites of active bleeding. Upper gastrointestinal radiography with barium has been replaced with upper endoscopy as the diagnostic procedure of choice for suspected peptic ulcer. Usually treatment will involve killing the H. pylori bacterium if present, eliminating or reducing use of NSAIDs if possible, and helping your ulcer to heal with medication. Antibiotics to kill the bacterium, such as amoxicillin, clarithromycin, metronidazole, levofloxacin. Proton pump inhibitors, also called PPIs, reduce stomach acid by blocking the action of the parts of cells that produce acid. These drugs include the prescription and over-the-counter medications omeprazole, lansoprazole, rabeprazole, and pantoprazole. Acid blockers, also called histamine, H2 blockers, reduce the amount of stomach acid released into your digestive tract, which relieves ulcer pain and encourages healing. These include the medications famotidine, cimetidine, and nizatidine. Antacids that neutralize stomach acid. Medications that protect the lining of your stomach and small intestine, such as sucralfate and misoprostol. Lifestyle modifications include patients with PUD should eliminate or reduce psychological stress, cigarette smoking, and the use of non-selective NSAIDs, including aspirin. If possible, alternative agents such as acetaminophen, a non-acetylated salicylate, example salsalate, or a COX-2 selective inhibitor should be used for pain relief. Although there is no need for a special diet, patients should avoid foods and beverages that cause dyspepsia or exacerbate ulcer symptoms, example spicy foods, caffeine, alcohol.